All right, well, we will go ahead and get started. Welcome everybody to today's webinar hosted by the Oregon Office of Rural Health. I'm Sarah Anderson, and I'm the Director of Field Services at the Office of Rural Health. And the webinar you're attending today is titled RHC Regulatory and Operational Update, presented by Jo Raebel from Wipfli. Jo has more than 19 years of experience in audit and accounting services focused exclusively on healthcare industry clients. She specializes in assisting freestanding and provider-based clinics to navigate through rural health clinic certification process and is a proven thought leader with vast experience in the RHC arena. Jo helps to calculate RHCs Medicare and Medicaid rates, provides education regarding changes in billing because of, because of certification, and consults on all areas specific to RHCs. In addition, she provides education regarding changes in billing because of certification. And oops, I already read that part. Sorry about that. She helps organizations determine the best certification options to experience the most beneficial gain from Medicare and Medicaid reimbursement. Jo is a regular speaker at industry events and conferences such as the Rural Health Clinic Association of Washington, the Oregon Rural Health Conference, and the National Association of Rural Health Clinics Conference, just to name a few. Before we begin, I have a few housekeeping details. The webinar is being recorded. Eric Jordan, who is a co-host here, will post the slides and recording on ORH's website within the next few days. And thanks also to Eric for being our tech support during the webinar. If you encounter technology problems, enter your question into the chat box and he will assist you. And you're currently all muted and your video is off. Jo is happy to answer your questions during any time throughout the presentation. Enter your questions in the chat box on the right side of your screen, and I will read your questions aloud. I will also put a survey link in the chat box. If you could please, and I'll do that at the end of the presentation so that you can complete the short survey at the end of the presentation to let us know how we did and how we can support you. Again, thank you to Jo, and I'm going to pass the baton off to her.
Thank you, Sarah, so much. And it's good to be here with all of you. I'm seeing some familiar people on the webinar, so that's great. And again, if you have questions, feel free to stop me. We have an hour, and I'm happy to answer questions as they come along. So we have a lot of changes in the RHC world, and want to make sure you're aware of them all, and that's what we're going to be going over today. Basically, our agenda and our learning objectives for today's session is we're going to learn about those new changes and how they affect your payments for your rural health clinics. And more than that, what strategies can we implement for managing through these new payments? And then there's some risks and issues that you should know about regarding RHCs, that there's still lots of unknowns regarding this new legislation that you want to be aware of in case you're going to have any changes relating to your clinic. So we're going to go through those as well. So we'll talk about these RHC changes. I'm going to touch on some brief advocacy issues, initiatives that some organizations are still working towards. We'll talk about strategies under the new payment methodology, and then talk about some additional considerations. And then if we have time, of course, we will go through your questions. Okay, so what happened in the RHC world? Well, we know that at the end of December, President Trump signed into law the Consolidated Appropriations Act of 2021. And in that was part of the RHC Modernization Act that was included in that bill. And what happened was it really increased reimbursement for independent rural health clinics. So previous to the changes, rural health clinics were limited to about $88 in 2021, and that was increasing only by what's called the Medicare Economic Index, a small inflationary factor every year. We know that most, if not all, freestanding rural health clinics are well in excess of that cost per visit, and they were kind of being unfairly limited to this amount. But also what happened was these changes not only affect freestanding rural health clinics, it's also affecting provider-based RHCs. So any newly certified RHCs would be set at these increased limits, even if you were provider-based to a hospital of less than 50 beds. We'll talk about that in a little bit as well. But basically, we have changes to a cap. So the cap increase for freestanding rural health clinics, but provider-based RHCs are also subject to those cap if they're newly certified, and we'll talk about what's newly certified in a little bit too. Existing provider-based RHCs or grandfathered RHCs, it was indicated, would be subject to a new base rate that would be inflated forward by that MEI. So no longer being settled up every year at the actual cost per visit. If you were a rural health clinic that was provider-based to a hospital of less than 50 beds, you were settling up every year on the cost report to your actual cost per visit. So this new legislation also kind of put in a cap for provider-based RHCs that were in existence and grandfathered in, and I like to really refer to it as a PPS cap, and we'll discuss that a little bit further. It also allowed for RHCs to bill for hospice services beginning in 2022. So this is the new limitation here. So previous to April 1st, freestanding or independent RHCs or provider-based RHCs to hospitals with more than 50 beds had this cap of about $88. After April 1st, that cap is increased to $100 per visit. And that is going to be increased to $190 in 2028. And this is the schedule that it's going to be increased over. Once we get to $190 in 2028, that 190 will be increased by the Medicare Economic Index, which has been hovering about, 1.8%. So it's a really minimal amount. It definitely doesn't keep up with inflation, but it is a small inflationary factor. So after, again, we get to 190, it's going to be increased by the Medicare Economic Index. Excuse me. Again, this is independent RHCs and newly certified provider-based RHCs. We'll go into the definition of that, but freestanding RHCs, you should be seeing an increase to your rate. If you're not receiving an increased rate, we want to reach out to your intermediary. But this cap of $100, keep in mind, you're getting 80% of your rate from Medicare and 20% of total charges from the patient on the Medicare side. So this doesn't mean that your total payment is going to be $100. It's that your rate that Medicare is paying you based off of is increased. So you should be seeing about an $80 payment from Medicare for your services. The original legislation that was signed indicated that newly certified RHCs were those certified after 12/31 of 2019. So we had a lot of rural health clinics that were certified in 2020 that were panicked because they had, built pro formas off of a certain payment methodology, and here they were certified in 2020, and now all of a sudden the rules had changed. So the intent was, according to the National Association of RHCs, was that it was supposed to be a 12/31/2020 date, and clinics certified after that date would be considered new. In April, there was a bill that was signed into law that included a technical fix to correct that date to 12/31/2020 and really specified that clinics that had an 855A in prior to 12/31/2020 would be considered a grandfathered RHC. And so really that kind of made the clinics happy that were in process. We have those clinics that were certified in 2020 that would be provider-based to a hospital of less than 50 beds, still being based on a cost-based rate. So for these provider-based clinics, they're going to be paid based on a cost-based rate, and that rate is going to be inflated forward every year. And the lesser of our actual cost per visit or our base rate is going to be the payment methodology that we're going to get paid off of. And this is from the law. Basically, it tells us that that clinics that were certified in 2020 will be paid based off of payments made in 2020. That's confusing. We're going to talk about that. And clinics that were certified after 2020, so in 2021, they're going to have a base rate based off of payments that were paid in 2021. Well, what's that mean? We'll dig into that a little bit further, but this is the law right here, and we'll talk about what's really not specified in the law and where our risks are. Let's talk about some further advocacy initiatives. So first of all, we had the legislation that went through. It was a bit of a surprise. Obviously, again, we had clinics that were certified in 2020 that would have been out the cost-based rates that they were expecting. And it was moved forward by NRHA and the National Association to get the technical fix in. There's some other initiatives. I know NRHA is working on some others. You can go to their website and look at what things they are pushing for. They are actually pushing for no cap on provider-based RHCs, that this would kind of be undone. And the payment for that would really be quality reporting. We know that rural health clinics are not subject to quality measures right now. And so this would actually be kind of a good time to say, hey, we know that this is probably coming down the pike anyhow. We're probably going to have to do it anyhow. Could we get cost-based reimbursement in exchange for quality reporting? That may be something that's going through. They're also pushing for outdated laboratory requirements to be either reduced or removed altogether. So right now we know as a condition of participation in the rural health clinic program, we have to have the ability to perform those 6 lab tests. A lot of our clinics may have the ability, but they're not really performing those lab tests anyhow. It's kind of outdated. Again, the RHC program went into effect in 1977, and this really hasn't been updated. So there's some things here that they're working on. I'm not going to go through all of them, but those are some important ones, and great organization to be in touch with regarding these items. And the National Association of Rural Health Clinics did push for also that change from the 12/31/19 date to a 12/31/2020 date. They're also looking at another bill that actually supports clinics that were in mid-build or in process to be in a grandfathered rate. So let's say we have a clinic that you're constructing right now and you couldn't submit an 855A at the end of the year because you didn't even have an address yet. You hadn't broken ground, but you had done all the work. You have architects fees paid. You know, you're working towards building a big MOB, but you couldn't have even submitted an 855A. Those are the types of clinics that we're talking about that when we're talking about mid-build. And this is actually getting some Senate support. I have some clients in the Midwest that are really pushing towards this. I encourage you, if you have a situation that may put your grandfathered rate at risk, please reach out to me. We're trying to get as much information from RHCs across the nation in order to get a concerted effort to get these changed. And I would love to hear from you. So please reach out to me. All right, strategies under the new payment methodology. So just some observations here. We know that for grandfathered RHCs, we have, you know, a base, I like to call it a base PPS rate. So let's say our base PPS rate is based off of our 2020 finalized Medicare cost report, which, by the way, your Medicare cost report for this year is very important. Do not overlook the importance of your rural health clinics on your hospital cost reports. If you are a grandfathered RHC that will get a base rate, it's still kind of unknown what that base rate is going to be based off of, and it could potentially be this 2020 cost report that is due, well, normally would be due at the end of this month, but it's now due at the end of July. So very, very important. I recommend, if you are hurrying to get your cost report done in the normal amount of time and you have some time to really dig into your cost report and take that extra month or two to look at your rural health clinics to see how you could optimize reimbursement in your RHC, get that rate as high as justifiably as you can. Of course, you want it correct, but take that extra time and really look at it. That's going to be your rate indefinitely until some other legislation passes that would either undo that or any other changes. You're going to be living with that rate forever. So really, really focus on your cost reports. But we know that that base year, it could be derived from the 2020 cost report. There's some other, could be based off of your interim rate for 2020. What we do know, though, in 2020, obviously, we've had a very different year. And there is the option to request a productivity standard waiver from Medicare. So that's always been in effect. Clinics have always had the ability to request a productivity standard waiver from CMS. And really the request goes to the Medicare administrative contractor. In the waivers for COVID, the question was asked, are productivity standards going to be waived during the public health emergency on the Medicare cost report? And CMS said, you're welcome to file a productivity standard exception. We encourage clinics to. It's up to the MACs to decide whether or not it's granted. And they've always had the ability to do that. What we do know is that in the past, productivity standard exceptions have been very rare. During the public health emergency with the clients that I work for that we've been requesting a productivity standard exception, we've gotten them all approved. Now, what does that mean? That doesn't mean that they won't add some productivity standards on when they do a final desk review. So it's not like they'll be wiped out completely necessarily, but we do know they'll probably be reduced. So on your to-do list, if you have not requested a productivity standard exception and you are a provider-based hospital with less than 50 beds, this is very important. If you do have a productivity standard issue on your cost report, you're going to want to request that. So just kind of a reminder, on your Medicare cost report, really we're trying to get to a goal of what's the clinic's cost per visit. You have costs divided by the greater of actual visits or productivity standard visits. And if our actual visits are less than productivity standard visits, we're actually getting a reduced Medicare cost per visit. And again, if this cost report is going to be used for our final Medicare rate, and they're going to allow us to have our productivity standards reduced due to COVID, we're definitely going to want to request that. On the freestanding RHC side, this really isn't an issue unless you aren't meeting the $100 cost per visit for 2021. If your cost per visit is coming out less than $100 because you're underproductive, you don't have enough costs, then that's something that we would probably want to request. But that's going to be really far and few that that would affect. So this is mainly a provider-based RHC issue. So we will see some rural health clinics that will experience, again, increased rates. This is a really great win for freestanding rural health clinics, right? We no longer have this $88 cap. It's going to be increased from $100 to $190 in 2028. That's great. We also have provider-based RHCs to hospitals with more than 50 beds that are capped. And you ask, well, why even make it provider-based? Well, 340B might be a reason why they have provider-based RHCs, because you have to be provider-based. If they have some other reimbursement wins because the clinic is considered provider-based, that may be why. But these clinics have been also subject to that cap, and they would see an increase as well. Medicare Advantage, this is kind of another to-do from this is you want to go back and look at your rates from your Medicare Advantage plans. Medicare Advantage plans are not required to pay your clinic at rural health clinic rates. Really, they're considered commercial plans. You contract with them how you want to contract with them. And you definitely can negotiate higher rates. or you can negotiate RHC rates. If they are requiring your rural health clinic, interim rate letter every year, and your rate is decreased or increased, you want to make sure that you're maximizing your reimbursement from your Medicare Advantage plans. What rates are you getting now? What rates are you going to get? Would it be higher if you contracted with them at fee-for-service amounts? Probably not. If you get a percent of charge amount, those are the types of things that we want to look at. But we do know that they do not have to pay you at RHC rates, although it might be beneficial. So you always want to go and look at those. Keep in mind, they have no idea that you're a rural health clinic unless that you tell them. So if you're getting a $300 rate out of your provider-based RHC and you've never tried to negotiate a rural health clinic rate for those clinics from your Medicare Advantage plans, you want to go and do that. We have some clinics that kind of forget to do that. I'm going to pause there. Sarah, do we have any questions so far?
I don't see any yet, Katie.
Okay, great. And there's the chat box, right?
Yep.
Okay, just a reminder, if you guys have questions, I can certainly pause if you put something in the chat box. So who's at risk if provider-based RHCs that have a cost-based grandfathered rate are going to be kept whole, and if freestanding RHCs are getting a rate increase and provider-based RHCs to a hospital more than 50 beds are also going to see an increase, what's our risk? Well, the risk is these provider-based RHCs that were before uncapped, they're going to be the ones at risk the most. And the reason being is because, yes, we'll get this, again, what I like to call it is a PPS capped rate. We may have a great rate. Let's say we have a $250 base rate that's increased by the Medicare Economic Index. But the next year, we're building a big MOB and we're going to move the clinic. Those costs, yes, they're included in our all-inclusive encounter rate, but only up to that $250 rate. So if our rate increases to, our actual cost per visit increases to $275, and we would normally get reimbursed that from Medicare, it's no longer going, we're not going to get reimbursed for those additional costs. So that's going to be significant. What if we have clinics that have added on specialty services? We have to be predominantly primary care, but you can have specialty services within your RHC, like orthopedic specialists, podiatrists, mental health, chiropractic services. Let's say you are working on a big initiative to put all of these providers in one rural health clinic. What's then going to happen to your rate? It may increase your actual cost per visit, but you've been set on this base rate that didn't include all of those costs. So that's where we're at risk. Clinics that are undergoing a change of ownership, these may be at risk as well. We have no idea whether a change of ownership is going to affect a grandfathered rate. Even if we're going from provider-based RHC to another provider-based RHC, for example, I have systems that have moved rural health clinics from one hospital to another. Let's say we have a critical access hospital that they're currently provider-based to, but we actually have a PPS hospital, less than 50 beds, that we can attach that rural health clinic to, and then we don't have a drawdown of overhead that affects cost-based reimbursement out of the hospital. That's usually been a win. But if we do that now, will we lose our grandfathered rate? And we just don't know. So that's something that's at risk. To illustrate kind of these new payment limits, this is a freestanding RHC, and this is based off of NARC's interpretation and what CMS has told them. So I want to tell you that this isn't from CMS. This is really from NARC and what they have talked to CMS about. We know CMS can always change things. What we know, there's all these unknowns. It's my understanding with conversations with NARC that CMS has to interpret the law, and rather than interpreting it outside of, on its own, the RHC portion, they're actually going to interpret this as part of the physician fee schedule rule. That'll be in July, likely. They'll have a comment period, and then it'll be finalized in November. So we may not know about many of these questions until late, this year, and we're trying to make decisions. So that's the other thing. If you have something at risk, please let me know, because I'm trying to get those items to CMS and to our friends at NARC and NRHA to see what things they can kind of move forward and we can get some answers on. So this is what NARC's understanding of how the rates are going to work, and if our actual cost per visit is less than the cap. So amounts shown in red indicate that the limit is the payment amount, and amounts shown in green indicate that the RHC actual cost is the payment amount. So you can see on the top line, these are all of the new upper payment limits. We had, again, about $88 prior to 4/1 of 2021. That's when our $100 rate increase for freestanding RHCs and provider base to more than 50 beds. Again, that rate is slowly increasing, getting to 190 in 2028, and it'll be increased by the Medicare Economic Index after that time. For this particular clinic, their cost per visit in 2021, this is their actual cost per visit that's calculated on the Medicare cost report, was $95. So they're above the cost per visit limit. They're going to receive payments based on $88. Same thing in 4/1 and after. They have an actual cost per visit of $105. They're going to get that max rate of $100. But when we look at 2022, we can see that their actual cost per visit is $110, and they're going to be paid the lesser of the cap or their actual cost per visit. So the Medicare cost report is still going to be a very important component of a clinic's to do every year. We're still going to have to complete this. It still matters what your actual cost per visit is calculated at, because if we are falling short of the cap or our PPS grandfathered cap, we're going to get the lesser of the two. So we need to make sure we're really paying attention to that. And for, freestanding RHCs, we kind of want to hit the sweet spot where we're maximizing our reimbursement rates. And if we can get to that 190 cost per visit, that's kind of where we want to be. Of course, costs, we want to be viable as a clinic, but part of that is maximizing our RHC Medicare rates as much as possible. For provider-based RHCs, some strategy, do we want to keep services in the rural health clinic, or if we're considering putting new services in a rural health clinic, do we really want to do that? It might still be really advantageous, but maybe we might want to look at a hospital outpatient department. What would reimbursement look like under there? It might be something to look at. I always recommend analyzing whenever we put new services in an RHC or we think about taking them out. What is our overall reimbursement effect? And we have to keep in mind that this not only affects Medicare, right? That can affect your Medicaid payments, and we just want to make sure that we look at everything. So, keep that in mind. In the state of Oregon, whenever you have an outpatient hospital department, you actually have to have that location licensed under the hospital. So that's something to keep in mind, and maybe a deterrent from adding a location on as a hospital outpatient department. And then you have to meet, location requirements and provider-based requirements. So there's more to consider here as well. But it's always something to look at. We want to make sure that we are optimizing our reimbursement as much as possible. Payer mix of that particular service line is going to be really, really important. It may or may not matter on the Medicare and Medicaid side, because maybe we have a service line that's not utilized by Medicare and Medicaid. So analyze. This is going to be really important for clinics, especially in Oregon as well. So what we know right now is these changes are specific to Medicare. If Medicaid was to adopt these changes, there would have to be a state plan amendment. It would have to be approved by CMS. Do I see it changing? Possibly it could, but I have not heard any rumblings that that's going to change. What we want to make sure of is that our RHC Medicaid rates are maximized. Oregon does allow for a change in scope request. So right now, even newly certified RHCs certified after 2021 on the Medicaid side are going to get full cost-based reimbursement, right? A cost per visit. Oregon also does not utilize productivity standards, which is amazing. One of the only states that I know that doesn't implement productivity standards in the RHC cost per visit calculation. So right now, as it sits, we're getting full cost-based reimbursement with no productivity standard, reduction of cost. We have the opportunity to request a change in scope. And what this is if we add on new services to our RHC that were not part of our initial RHC PPS rate calculation, we can request a change in scope. And although it's not a full rebasing of the rate, we may be able to add on costs to our rate that gets us higher than what we were before. It's kind of a process in the state of Oregon, but there is that opportunity. It has to increase by a certain amount. You get the incremental cost added on. It is a process, but it's possible. So, you know, look at your rates, maximize your RHC rate. And what I want to point out is I've had a lot of clients and people ask me, well, does RHC even make sense anymore? I really think it does. You know, we've seen for years freestanding rural health clinics that have actually, they've suffered a loss on the Medicare side, but their gains from Medicaid, especially in the state of Oregon, have been so great that it makes total sense to move forward with RHC certification. And again, it depends on what your payer mix is for a particular clinic and service line, but it can still definitely make sense, even if you might be losing on the Medicare side a little bit. So keep that in mind. Again, analyze. Specialty services, I talked about this, maybe high cost specialists in the RHC, you know, maybe you might want to reevaluate that. If you were considering putting specialists in your rural health clinic, would it be better in a different department? You know, looking at that, we might want to move, if we have multiple rural health clinics, maybe we put some services in one rural health clinic and not in another. That might be an opportunity as well. Again, moving some of those services outside of the RHC setting. We've got school-based health services that we have the opportunity to provide, especially in the state of Oregon. We can actually go outside the walls of the RHC, and CMS, or sorry, the state of Oregon has said we can still bill those under the clinic's provider number. So there's some opportunities there. We don't have to be within the walls of the RHC like we have to be for Medicare. So again, there's some opportunities to look at that. This is a big one right here. Mobile rural health clinics are getting a lot of consideration because you can have a mobile rural health clinic and it actually utilizes an existing Medicare number. So we don't have to go through a new certification. It would be part of a grandfathered rate. Let's say we have a rural health clinic that has a grandfathered rate of $250. We could add on a mobile RHC. It could actually be in a permanent location, but it's considered mobile, and we could get those rates for that RHC. If you are utilizing a mobile RHC, there are some requirements. One, we have to make sure that the services are still located in a HPSA and a rural area. You have to have a consistent schedule. So we can't one week say we're here on, you know, Monday, and then next week we might show up on, you know, Wednesday. We don't have a consistent schedule. It has to be consistent. There are requirements. We have to check with the state and see what they require as well, because every state can be different. But I think we're going to be seeing probably a lot more mobile rural health clinics in the future for clinics that have a provider-based grandfathered rate. I think this is a really great opportunity for RHCs and something we're going to be seeing more of. Consolidation. So we have the opportunity, and always have had the opportunity, if we have rural health clinics that are under the same tax ID, whether freestanding or provider-based, we can actually consolidate cost reports. and for provider-based RHCs, they can be consolidated onto one line on the Medicare cost report. This may be a way to kind of select the clinic that has the highest AIR. We might be able to, if we consolidate cost RHCs onto one line, it might be beneficial for our Medicare reimbursement. What we don't know right now, though, is if we do consolidate them, what's the effect going to be on our rates? So this is kind of one of those unknown. Let's say we consolidated in 2021 and our cost per visit ends up being less than our base rate, then we're going to be paying some money back. So there's some things to consider here, but this may be an opportunity as well. If we have a physical consolidation, so let's say we have multiple rural health clinics that are certified. Keep in mind, RHCs are certified by address. And we have room to put services in an existing rural health clinic. Say we have, one clinic that has a rate of $350 and we have another clinic that has a rate of $250, and we decide to move the clinic services that were at $250 into the $350 clinic, we can now utilize that rate if we have room. I mean, obviously constraints would have to be considered regarding space, etc., but that might be something to look at too. I'm going to pause there and see what questions we have so far, if any.
We don't have any new questions in the chat box, Katie Jo, so okay. Go ahead and continue.
Great, okay. We're flying through. So some additional considerations. Again, big question is, how will the new base rate be impacted if RHCs are consolidated on the Medicare cost report? We don't know. Also, a big question is how our base rate will be considered for our provider-based grandfathered RHCs. It says it'll be based off of 2020 services. Payments for 2020 services will be our base rate. Well, does that mean your interim rate for 2020 and what you're paid based off of? Will that mean your submitted 2020 cost report or your finalized 2020 cost report? We see rural health clinics, especially provider-based rural health clinics and hospital cost reports that haven't been settled for years. So will we be really waiting for years to find out what our base rate's going to be? That's a question. For clinics that had an 855A in prior to the end of 2020 and are going to get certified in 2021, what will their rate be based off of? Well, it says based off of services in payments for services in 2021. What happens if you aren't certified until November or December and you don't start billing until January? Are you out a grandfathered rate? That's actually a real concern. We don't know. And we're trying to push getting answers on this. So that could be an issue. Or again, are they going to base it off of a 2-month cost report where you have minimal costs and don't really have a good view of a full year cost per visit? That's something else to consider, and why I'm kind of trying to push for answers. How are MACs likely to treat interim rates for 2020 given the potential for limitations on the AIR? We're already seeing some fallout from this, where clinics that, even though they had their 855A filed before the end of the year and were certified then in 2021, the MACs are giving them $100 rates, and that's because CMS has not updated their instructions to the Medicare intermediaries in order to get them the correct information that they should have a cost-based rate if they had an 855A filed before the end of the year. This is interesting too. What if a clinic submitted an 855A prior to 12/31 of 2020, but does not receive certification until 2022? We know, and I know personally from the rural health clinics that I've dealt with this year, I've had some that were working towards certification well over a year because they were dealing with a pandemic. Rural health clinic status is not an easy lift. you know, it's a process to go through. And during the pandemic, things are taking much longer. So we have clinics that may have submitted an 855A prior to the end of the year, but they still really need some time in order to get certified. And it may be until 2022 that they're certified. Will they receive a grandfathered rate? And there's rumblings. NARC has indicated that they don't know. CMS has told them that that could put their grandfathered rate at risk. I think what they're trying to avoid is clinics that submit an 855A or did submit an 855A at the end of the year and hold it indefinitely, and 5 years later get certified and then they decide they want a cost-based rate. I think that's what probably CMS is trying to avoid. But nonetheless, we know that these things take time, and a year, even 2 years, may not be out of the question for clinics that are seeking certification. Plus, we have the state the state of Oregon is still performing RHC surveys, but it can be, you know, months before you have a survey. And if you go through an accrediting agency, we know they are very busy as well trying to get clinics certified. I know they are crazy busy with everything that's happening. So you may just be waiting for a survey as well. If a clinic certified in 21, 20 and submitting 855A, what will the grandfather rates be based on? Again, really stressing provider-based RHCs with grandfather clinics. Please spend extra time on your cost report. Really make sure that your rates are going to be optimized and justified, and you know, anything that you can do to spend a little extra time looking at some things will be well worth it for the future. Will a change of address cause a grandfathered clinic to lose its grandfathered rate? I think I mentioned this before with the change of ownership, but even if you're to move your clinic at this time, we're not sure if that's a risk or not. And same thing with my discussions with NRHA and NARC. It's been indicated that this is a possible reason to limit a clinic's reimbursement rate and get rid of a grandfathered rate. So if you're looking at a change of address, again, please reach out to me. We're trying to push on this, and don't make any changes right away. We really need to consider this. And if you're a grandfathered RHC, this could definitely have an effect. And then again, will a change in ownership cause a grandfathered clinic to lose its grandfather rate? It is very possible that that could be the case as well. So closing remarks, you know, we know that things changed. They still could change. There still could be some fixes to the bill. There are people working feverishly to make changes. Again, if you're one of those people that want to be on that list of making changes and get behind that, please reach out to me, because there could still be some changes in the future. We know that right now current reimbursement has changed. We have to work within what we have right now, but we can use these strategies to mitigate the impact to our reimbursement. So analyze, really focus on your Medicare cost report. If you have any questions, please feel free to reach out to me, reach out to your cost report preparer, etc. If there's others in your organization that might not know all about this, they need to be, you know, they need to know if they're making changes in your clinic, there's going to be some changes to reimbursement in the future. So with that, I know we've got about 15 minutes. I would be happy to talk anything RHC. So if any of you have questions, not just about this, but anything RHC, we have 15 minutes. I would be happy to go over that with you.
Thank you so much, Katie Jo. And while we're waiting for questions to come in, I want to point out that I put the survey for this webinar in the chat box with a link. So please fill that out when we're done here today. And also a reminder, we've sent out initial information about the Oregon Rural Health Conference, which will be held in person in a modified format October 28th and 29th, house on the Deschutes Bend. And Katie will be there for our workshop look for more details on that as we get closer. Still waiting for questions to come in here, Katie Jo. We'll just give it another minute.
You know what? I'll mention a couple other things that I've been mentioning to Oregon clients right now. One, a big one and a benefit of being in Oregon. Oregon has actually indicated that they will pay for COVID administrations at the RHC PPS rate. So if you are not getting paid the PPS rate for those administrations, you want to make sure that you're turning those in. You'll get your full rate for those, which is great. On the Medicare side, if you're providing these out of your RHC, these will be claimed on your Medicare cost report and paid at cost. So this is just like flu and pneumonia. The difference is for this will be paid for Medicare and Medicare Advantage patients through the Medicare cost report. So it's really great that you don't have to be billing for them. We can keep track of them just like we do for flu and pneumonia injections and get reimbursed based on a cost per injection on the Medicare cost report. So
that's great. And I'll also mention that I do know that the state of Oregon is working on doing some reimbursement, getting $35 more per vaccination per COVID vaccination to RHCs through some FEMA funds.
Oh, great.
Yeah, so they are releasing tomorrow more information, which we'll make sure to get out to all of you about what that payment looks like and how to qualify for it. They're paying for it on a weekly basis, which is awesome. So
yeah, that's great. Okay,
yeah.
Good to know.
Yeah. All
We
right.
have a quiet group.
Yeah, I do. I am not seeing any questions. So so I guess we will give everybody a few minutes back today. Katie Jo, if you can stay on for just a minute.
Sure.
After we end here. So a reminder that the survey link is in the chat. And I really want to thank you, Katie Jo, for a really fantastic presentation. I know that these are really big questions that we all have, and I feel like you did a fantastic job of giving us a pathway to understand them. So thank you so much, and everybody have a great afternoon.
Thank you.